The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to have Camille Fung with us talking about neonatal opioid withdrawal syndrome. Thanks for being with us again. By the way, have you developed any disclosures over the last week?
No, I have not.
Okay. All right. We'll work on that. So one of the things when I saw your talk, one of the things that just really caught my attention is this shift in approach. Not only that we're not calling it abstinence syndrome anymore, as if babies need to get into a rehab program, but that the whole way that we approach this integration of I'm skipping ahead. I should let you talk about all this, but this integration of the treatment with the evaluation, I think is just so wonderful. So anyway, let's talk about this. So what's the ESC approach to managing NOWS?
Yeah, so ESC sleeps for Eat, Sleep, Console. And if we go back in history a little bit, it actually started with a group, Dr. Grossman. He's actually a pediatrician, I believe, at Yale University. So it was an initial quality improvement project that he embarked on in 2010, where he got all the stakeholders and said, we got to figure out a different way of managing these babies, because around 2010 was when we were starting to see an increase in neonatal opioid withdrawal syndrome. So to make it more functional, really, he said babies should be able to eat, sleep, and be consoled. Those are the three most important functional assessment pieces, rather than doing, you guys are probably used to the Finnegan scoring or modifications of it, right?
Tell us a little bit about that, because that's the background that we come from, is this scoring system to measure withdrawal.
Yeah, so thanks to Loretta Finnegan, in the 1970s, she was really the forefront person who was managing babies with neonatal abstinence syndrome then. And so she devised a scoring system where there were actually originally 21 items of scores that a nurse or caregiver would have to score for babies who they think are withdrawing to try to assess the severity of withdrawal. And I think it was great for the time, but if you try to do 21 items on a baby who's screaming and withdrawing, it is challenging, right? The things that we talked about, the hypertonicity, vomiting, diarrhea, like trying to get through 21 things in a short amount of time when all the baby wants to do is eat and maybe get a medication if they need it. So I think that kind of has been challenging for bedside caregivers, is to try to make the assessment and to try to treat at the same time. And so,
and one of the huge challenges with that is that you see this all the time, is that from shift to shift, you see dramatic changes in the scoring, because there is a certain amount of subjectivity, and that's not a criticism. This is an observation, and you're trying to give scores to your observation.
Yeah, absolutely. I think the inter-rater reliability was definitely not that great. And so the original 21 items, people actually have started to modify the Finnegan scale to bring it down so that really only, quote unquote, the critical symptoms are being captured. There's the Lipset scoring, there's the neonatal withdrawal index. All of these are just derivation of the original Finnegan scores. And so they were down to, I think, 11 items for both of them. But still, we're talking about 11 items versus eat, sleep, and be consoled. Three items.
Yeah. And the vital items, the things that predict success in transition.
Totally. I mentioned in the first episode, being able to eat, sleep, and be consoled really are the crux of trying to be a baby at the beginning of life. And so those are the functional pieces that Dr. Grossman and his team really kind of hooked onto, and then came out with this whole new process of how to assess babies with neonatal opioid withdrawal syndrome. So essentially, are they able to eat well within 10 minutes? Are they able to sleep for more than an hour? Or are they able to be consoled if they're crying in less than 10 minutes? So those were the three main variables that they looked at. And if you meet yes on all of them, basically you just continue non-pharmacological care.
And the
And
beauty of this too is that it involves the family or the dyad
Mhm.
as both part of the evaluation and part of the solution.
Absolutely. Again, we talked about how a lot of these babies may still have symptoms after discharge. And so I think arming the family upfront with tools and things to know how to help their babies when the baby withdraws, I think that it's just all going to be much more successful than the typical isolation from the baby, from the family.
So what are the strategies that are employed in this?
Yeah, so we always think of non-pharmacological maneuvers are the first line therapy. Medications were reserved more for babies with severe withdrawal. So non-pharmacological maneuvers include things like swaddling, being in a low lighting and low stimulus environment. Skin to skin is a big one if either the mother or the father could be at the bedside. And then just as providers, when we come in to do our daily exams, if we could cluster our exams together with the trainees and us, I think that would also help to minimize this overstimulation. And I think feeding is one. I would say breastfeeding is probably what we would advocate if the mother is also able to breastfeed, because that is actually the most studied non-pharmacological intervention for withdrawal. If not, then using formula is still okay. And we play with what formula is useful for these babies, but maybe sometimes using more lactose reduced or more digestive formula may be useful to help these babies with their GI symptoms.
Has this approach been studied?
Oh, has this approach been studied? Yeah. So because of the success,
I was pitching it slow. That was a slow pitch.
I know because of the success of what Dr. Grossman found in Yale, actually, even before a study was rolled out, a lot of centers were already starting to adopt it just in their own QI projects. But the NIH actually picked this up and enrolled. So this was an NIH funded study. They essentially enrolled 26 sites across the United States, and the University of Utah happened to be one of the 26 sites. And I had the fortune of being the site PI for this ESC trial. So it was challenging. This was happening in the year of COVID. I still remember we traveled to Washington to get official training on how to do ESC. I think it was like end of January of 2020. And then all of a sudden COVID happened, but this trial was still supposed to go on. So it took a little bit longer, I think, to enroll, but we got there. We started, I think, officially enrolling September of 2020, and it went on through March of 2022. And we got the number of babies that we needed to treat.
And what was the outcome?
Yeah, so the primary hypothesis was that babies who were treated with ESC would have a shorter length of stay compared to babies who were managed with what they call usual care, which is the Finnegan scoring, plus using whatever the medication of choice for the individual centers. In the US, I think more than 80% of centers use morphine as their first line, but there are other centers who may use methadone or buprenorphine. So the primary hypothesis ended up being correct in that they actually eat, sleep, console reduced the days of hospitalization by a little over 6 days, almost 7 days compared to the
That's
usual.
huge.
It's huge. Can you imagine a baby being in the hospital a whole week less
Right.
than what they would have been?
Well, and all the implications of the parents being commuter parents during much of that time, the ability to get home sooner and start real life, huge.
So yeah, so babies got home sooner. And so this was actually interesting. Babies who were in the ESC arm, they actually needed less pharmacological treatment. So it was about 66% less need for morphine or opioid. And interestingly, the babies who were in the Eat Sleep Console group actually needed the morphine, not just less in total dose, but later, because the non-pharmacological interventions really helped with the mild to moderate symptoms. But
Uh-huh.
then the ones who really were really severe, they sort of split that group up into those babies who really needed, almost like triage the babies who needed more pharmacological treatment.
So they started later with morphine. Were they able to stop it sooner?
Yeah, because the total length of stay was still shorter.
Okay. All right. And any change in adverse events?
So they have looked at the immediate adverse events like within the first 3 months. And so far, there's no change in terms of more urgent care or hospitalization. There's no more deaths. There's no more other adverse events that they looked at. I think the most important study that, or the follow up that hasn't been published, but it's the manuscript that is being drafted and edited right now, is the long-term follow-up. So this is the biggest piece, I think, for the Eat Sleep Console trial, is that, as you'd imagine, this group of patients is very difficult to follow because they're moving around all the time. They don't always come back for follow-up. But this is the first NOWS study in the United States where they're doing a Bailey's exam at 2 years of age
Uh-huh.
to try to understand what the long-term neurodevelopmental outcomes. And along the way, moms were also filling out surveys to try to understand their well-being, the baby's well-being, how the family dynamics is going. So it's a really comprehensive, and kudos to the NIH for coming up with it. It's just that this is a really rigorous long-term study to try to understand, are we doing the right things for these babies doing Eat Sleep Console?
What's the implication in the nursery itself? Does it change workflow or staffing in the nursery?
Yeah, I remember when we were talking about doing this at the University of Utah. So we actually started doing it in the nursery. So mother baby couplets and intermediate care nursery. We didn't do it in the NICU right off the bat because there are even more challenges with the babies in the NICU. But we rolled it out for the trial in the well baby nursery and the intermediate care nursery. There was a lot of angst. I would tell you, a lot of nurses were really worried about how we were going to do this.
Sure.
But I think the bottom line is that there's been a whole 180-degree change in terms of the buy-in now that they see how successful it is. And honestly, getting the parents involved, it almost is a little bit of stress alleviating because remember, you see nurses, they used to walk around these babies in the
Yeah.
nursery. And so they actually, it's kind of hard. But if you're actually telling the parents that they should be doing this, it's a little bit easier for the nurses if you kind of think of it that way.
Easier for the nurses and potentially very empowering for the families.
Totally. So I think it's just a whole mindset change that occurred. And for whatever reason, I think it alleviated a lot of the concerns at the beginning. In fact, we're starting to use it now in the NICU. The same concerns came up. We'll see how successful it is. We've only been doing it for about a month, but it is a little bit harder in the NICU setting because there are other medical things that are going on.
Sure. Now, obviously, there are going to be some cases where Eat Sleep Console isn't enough. Tell us about the pharmacologic management of these babies.
Yeah, like I mentioned before, the non-pharmacological interventions really take out, I think, the majority of babies who are having withdrawal symptoms. It really addresses the mild to moderate group. For those who really are severe, and I would say that just think of it, Eat Sleep Console is not to try to prevent babies from getting a pharmacological treatment if they need it. And that was actually one of the concerns. And many centers who were trying to enroll, the NIH was trying to get people to do it at the beginning. There was a lot of criticism that we're doing harm. We're actually not giving babies a drug when they need it. And that really is not the goal of the study. The goal of the study is you give the baby whatever the baby needs,
Right.
but you just use the non-pharmacological interventions first, right? Rather than just giving them a drug without doing the other things. And so for the babies who have more severe withdrawal, you ask those 3 questions that we talked about. Are they eating, sleeping, being consoled? And if you have no in any one of them, the algorithm is that then you huddle with the parents. So the nurses and the parents huddle And you basically try to go through the non-pharmacological intervention list to see where can we reinforce non-pharmacological care first. Is there something that we're not doing that can maximize the non-pharmacological interventions? And then you do it, right? You maximize, and then 3 hours later, you do it again. Can the baby eat, sleep, and be consoled? If there's another no, then at that point, that tells you that maybe this is a kid who needs a pharmacological intervention.
What interventions are usually used?
Yeah, so like I mentioned before, most units start with morphine, and that's the standard of care that we have here in Utah as well. But there are some units, even here in southern Utah, they use methadone in their unit.
Mhm.
Buprenorphine hasn't really taken off yet, but there's actually another study that is being conducted now to try to decipher between the utility of morphine versus buprenorphine as a postnatal treatment. And so buprenorphine has been difficult because the ready to use preparation has some degree of, I think it's a lot of alcohol because it takes the
Oh,
alcohol to
the
solve the
uh-huh.
buprenorphine. And so I think they use buprenorphine the most, Jefferson in Philadelphia. And they actually have an in-house alcohol-free preparation of buprenorphine. And so they have the most experience of using postnatal buprenorphine. And they're the center who's actually trying to see if there's a difference between comparing buprenorphine and morphine.
It seems in the past there have been other non-opiates used for babies who have withdrawal issues. I'm thinking particularly of phenobarbital, maybe. What's the role for those medications?
Yeah, so the opioid is the first line, but if the opioid is insufficient to manage the withdrawal symptoms, at least here at the University of Utah, we have two what we call adjunctive medications. So depending on the exposure, if the exposures are mostly opioid, we actually pull out clonidine, which is an alpha 2 agonist to use as an adjunctive. And again, reminding people that this is a CNS hyperexcitability. And so an alpha 2 agonist essentially tries to block that sympathetic outflow from the brain so that you have lesser withdrawal symptoms. So that's the more predominant opioid exposure. But many mothers are polysubstance exposed, so meaning that they cross multiple classes, right? So you have an opioid, you may have a benzo, you may have nicotine, you may have some methamphetamine. So the polysubstance exposed, we tend to pull out phenobarbital as the adjunctive therapy. And the reason we did it this way is because clonidine in previous studies have only been studied in the setting of opioid exposure.
Oh, I
So we
see.
just kind of tried to be more dogmatic and just kept it with the opioid substance.
Very interesting. Anything else we ought to be thinking about with the in-hospital treatment of? We're next week. We're going to talk a little bit about the kids going home, and also talking about some of the testing that we do. Anything else? This is fascinating stuff.
I think if you guys are trying to do it in your hospitals, is just get all the stakeholders together before you roll it out. Is get the nurses, the nurse managers, make sure that social workers are on board because everybody is going to take a piece in this, and also space is a huge issue. The ability for these parents to be at the bedside, if you're all crowded together, it makes it more challenging to do eat, sleep, console, as you can imagine, if you're on top of each other.
Yeah.
But private rooms are awesome, and even a place for the mother or the father to kind of walk away from the baby for a little bit in between care so that they get some reprieve and a bit of a mental break. I think space, like I said, it's always something we talk about in our meetings to try to understand how to make this a more friendly environment for the parents to be at the bedside.
One of the things we talk about all the time is when and how should we collaborate? It seems like clearly many of these babies can be managed very well in a nursery. At what point should I be talking to someone like you?
I think if you're really stuck, you're not moving forward with your non-pharmacological treatment, I think everyone can do. I know some level 1 nurseries, if you need morphine, they have to be transferred out. It's different for level 2s. But even if you're in a level 2A or 2B nursery and you're on a morphine and you're stuck again and you're thinking about a third line, not an adjunctive medication, it's always good to consult us because we may be able to help you figure out which one. And then I always ask the referring pediatrician calls me, just go over the substances with me. What are we talking about that this baby is exposed to? So that I can really try to help you figure out what's the right
And,
treatment.
and by that, you don't just mean what's on the MAR. And you may need to cast the net a little more broadly, because here you're talking about the opiates, but you're also potentially talking about SSRIs. You're talking about nicotine and ethanol and basically everything.
Yeah, even if you can even have a conversation with the mom, that's what I try to do actually is, yes, I have all this information in the electronic medical records and I have drug screen tests, but she may not tell you about an over-the-counter thing that she's
Yeah.
doing, right? I've had a baby who actually the mom was taking Unisom for sleep,
Uh-huh.
and the baby was having some withdrawal relating to that. And so I think even over-the-counter things or even herbal teas, sometimes I find some interesting mixture of things in herbal teas. So I think it's just important to kind of talk to the family and just say, merely my goal is your baby's having severe withdrawal and I need to figure out what I need to do to help your baby.
Yeah, and people may not think about mentioning unregulated substances like kratom, for instance. And
Kratom is a big one.
yeah, if I'm managing this baby in a community hospital, at what point should I feel like I'm out of the woods, that it's safe to send them home? Because again, there are the issues of metabolism and various substances. How long should I watch a baby before I send them home?
Yeah, I think if you were on a medication, make sure the baby's off it for at least 24 hours. I think 48 hours is probably safe. 24 to 48 hours is safe. But I think what is most important is just because they leave doesn't mean they're going to be forgotten. They need to have the pediatrician follow up right away within the next day or two. And again, we can talk about other follow ups that can occur in another forum, but the baby needs to be seen by the pediatrician right away after they get out of the hospital to determine how much more often the pediatrician needs to see the baby.
And in a very real sense, this is one of the advantages of as much management in a nursery as possible. And otherwise, if possible, that if a baby needs to be at a higher level of care, that some sort of contact, if they already know a pediatrician, that the pediatrician is interested. And if they don't, that we figure out some way to get to know each other.
Yeah, and I know oftentimes when a baby's been placed on clonidine, we actually try to wean the baby off the clonidine before we send that baby home because of the rebound effects of tachycardia and hypertension, which will be very difficult to try to track as an outpatient. I think phenobarbital is different because many pediatricians are comfortable with phenobarbital management as an outpatient, and you don't actually have to actively wean, you just let the baby's weight gain outgrow the dose. So there isn't actually anything active to do from fasting.
Do get the impression we have less experience with phenobarbital than we used to have.
That may be true with the newer trainees and newer pediatricians.
But the beautiful thing, though, is that not only are we not titrating doses up, but we're letting them outgrow the dose, which is a great thing. Well, Camille, this is very fascinating. Next week, we want to talk a little bit more about post-hospital care and a few other care issues. Thank you so much for your time and expertise. This has been very interesting. For those of you who have questions, please send your questions to questions@thecurb.com. We'll deal with those in a couple of weeks. And in the meantime, thanks for listening and thanks for being with us, Camille.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.